Our last talk for the day is a very important topic, pre-diabetes and cardiovascular risk. We know about diabetes and cardiovascular risk, but there is double the number of people who have got pre-diabetes and they have cardiovascular risk, as has been described by Dr. Tadej Batilino just a few lectures before. Even 30 years before they develop diabetes, they can have cardiovascular risk. So now I call upon Dr. Sanjay Agarwal to come to the podium. And before you give your lecture, we are going to give you a memento.
Thank you very much, and thank you, Jyoti, for inviting me for this important meeting. I know it's just the end of the day and mine is the last lecture, and you've had 3 great lectures before me. So I'm just going to try and be very brief and specific to the point of what I really want to say. All this while, we always keep talking about diabetes and cardiovascular risk, but seldom do we really look at pre-diabetic population as to how important this population is in terms of cardiovascular disease or cardiovascular risk. And that's perhaps the reason that we don't put too much of stress on mild dysglycemia. That's where actually we make a mistake. So let's look at some of the evidence that we are going to see that how pre-diabetes actually predisposes people for cardiovascular disease. Now, from the ICMR in DIAP study, we have been familiar with these numbers, and I don't want to go over it all over again, where we say that we almost about 247 million population has pre-diabetes or diabetes, of which about 136 million has pre-diabetes. But along the spectrum, you can see the host of conditions that predispose to cardiovascular risk. That's hypertension, obesity, hypercholesterolemia, high LDL value. All these are potential drivers for cardiovascular disease. And if you look at the India data all across the country, you find that even with the urban-rural divide, you find that the incidence doesn't change of all these points that I've really talked about. And here's some excellence. So hypertension, about 35% cumulative, abdominal obesity, 39%, generalized obesity, 28%. If you look at dyslipidemia, 80%, and that's broken down into hypercholesterolemia, low HDL, hypertriglyceridemia, and high LDL cholesterol. You find that every part of the country is involved, and urban, rural, both are actually involved. So there's not much of a sort of a change that you see between these groups as such. So why are we really concerned about cardiovascular risk and whether it's pre-diabetes or diabetes? 80% of all diabetic mortality comes, 75% of which comes from coronary atherosclerosis, and 25% from cerebral and peripheral vascular disease. The dictum being that if you have stenosis in one vessel, always look at stenosis in other vessels. There's always a high probability that you'll find stenosis elsewhere. And more than 75% of hospitalizations are from diabetic complications. And more than 50% of newly diagnosed type 2 diabetes have existing coronary heart disease. Now, if we make a tall statement that patients who come to with pre-diabetes may already have existing cardiovascular disease or cardiovascular risk, it should be substantiated as to why this really happens as such. So what are the metabolic abnormalities that we see with type 2 diabetes? And we're familiar with the slide. We see high insulin resistance, high triglycerides, low HDL, and increase in small dense LDL particle concentration. Of course, obesity is the driver and the mother of all problems. But in this entire complex diagram that you see, which leads one to the other, I've just marked out the boxes that really remain important. That's insulin resistance, atherogenic LDL, hypertension, hyperglycemia, and all these through multiple pathways leads to macrovascular complications. Let me make it a bit more simpler for you. So you've got hyperinsulinemia, insulin resistance, and at some point of time it leads to dysglycemia. Now through all these inflammatory pathways that you see over here, it leads to accelerated atherosclerosis and endothelial dysfunction and arterial stiffness, which predisposes the patient to developing vasculopathies. So if you look at patients who come to us, right, we talk about does good glycemic control change the micro and macrovascular complications? While there's evidence that microvascular complications do tend to get benefited by tight glycemic control, but where macrovascular complications are concerned, it's a host of all cardiovascular risks that you see over here. So whether it's genes at play, weight gain, dyslipidemia, hypertension, and impaired fasting or impaired glucose tolerance. So it's a conundrum of risk that exists with the patient, which puts the patient at a high cardiovascular risk of cardiovascular disease. So often these come together, and dysglycemia may be just one part of this risk that the patient carries. So when patients come to us with prediabetes, this patient may already be having these risk factors, and patients may present to us with cardiovascular disease rather than as a consequence to the dysglycemia that we are really talking about. So when we talk about microvascular complications, it's consequential. And that's why tight glycemic control would help us. But when you look at this entire spectrum of risk that the patient carries, it makes sense that you need to have multiple risk interventions other than just getting glucose in control, where you're going to reduce the cardiovascular risk of the patient. Now, having said that, if you look at the host of problems that the patient will tend to get, with prediabetes, patient has of course high amount of circulating pro-inflammatory cytokines, endothelial dysfunction, but it puts the patient at a higher risk for stroke, peripheral vascular disease, myocardial infarction or coronary artery disease, or congestive heart failure. And there is evidence to show that if you look at two ends of the spectrum, where a patient is completely normal and the other end the patient has got diabetes, and you're plotting out all the pathways which will lead to an increased cardiovascular risk, then where does prediabetes lie? And you can see the study by Ralph DiFranzo, where they looked at impaired fasting glucose and impaired glucose tolerance. The risk comes closer to overt diabetes and not towards the normalcy, right? So if you see the intermediate dotted lines out there, they're much more closer to patients who've got diabetes. So the risk equivalent of a prediabetes is as much as patient would tend to have closer to diabetes rather than being normoglycemic. And this has been seen in a host of studies. It's not just ASCVD that we talk about. We talk about CKD, we talk about heart failure, and if you look at where does the risk profile lie of a pre-diabetic patient, it's always closer as much as or probably lesser than what would be with a patient who has established diabetes rather than somebody who's got no diabetes as such. Now, we always say that our cutoff points for diagnosis, and we say that okay, 5.7% that we look at, and that should be the cutoff point. So does that mean that the cardiovascular risk becomes zero below that? And here's the answer, that if you look at this EPIC NORFLOX study, they plotted the graphs backwards with women and men, and they looked at coronary heart disease and cardiovascular disease and all-cause mortality in patients at different subgroups of HbA1c. So they didn't start at 7%, but they went all the way down to less than 5%. And you can clearly see here that it never touches the baseline. So patients who are destined to develop cardiovascular disease, the risk starts much earlier, even within the normal range, and doesn't actually start at a later point of time. So you have to identify the high-risk population and start intervening early rather than be late in waiting for the blood glucose levels to go very high and then start doing the intervention as such. So clearly, the risk is even within the normal range, and that's why I always say that you need to see trends of change rather than absolute values, because if you're looking at just absolute values, you're going to miss the bus. And if you have somebody who's, comes to you with a A1C of 5.2 and you say, okay, this is completely normal, I mean, fine, but he has got hypertension, he's got obesity, he's got a dyslipidemia, right? Now, this patient at 6 months down the line, or 1 year down the line, has an A1C of 5.7 and you wait for another 6 months, it's 6.1. Clearly, this patient is on the road for some problem, right? And unless you're marking the trends, you're going to just look at absolute value and mark this guy off as saying he's completely normal and a low risk profile. So marking trends of change and plotting them against other risk factors is the most important factor that you should always look at in your patients. And here's another study from the Nurses' Health Study, which again showed the same data, where they looked at no diabetes at baseline and known diabetes at baseline. And you can clearly see the A1Cs at low values within the normal range had definitely a higher risk as compared to patients, who were not destined to become diabetic, were not destined to develop cardiovascular disease. Now here's another data that if you see the index of non-diabetic throughout the study, and if you see patients who prior to the diagnosis of diabetes had a risk of myocardial infarction and stroke, after diagnosis of diabetes and then diabetes at baseline, clearly you see the risk escalation that happens as against somebody who's been non-diabetic all throughout the study. So progressors have a high risk as compared to the non-progressors. Now, if you see the conversion rates of pre-diabetes to diabetes, you find that about 10 to 15% of patients who have pre-diabetes will convert to diabetes. So does that mean that the non-converters have low risk and they will have no risk? And here's the data that showed from the ERIC study, which looked at about 10,000 patients studied over 30 years, one of the longest studies. And they said that the non-progressors to diabetes and patients who stay in the pre-diabetes continue to have the high risk. So it's not that if you don't progress, your risk tends to come down. Even the non-progressors tend to have a high risk for cardiovascular disease. So there are 5 alarming facts of cardiovascular disease. We in Indian tend to have premature atherosclerotic disease 10 years earlier than the rest. Comorbidities like diabetes and hypertension strike at a younger age. There's a greater prevalence of LV dysfunction at presentations. If you look at our coronary angiograms, we have smaller arteries, and that makes difficult percutaneous interventions and complex CABG surgeries. So I have been stressing the fact that we need to intervene, and we need to intervene early. So why do we not really drive these prevention strategies much earlier, given the fact that we know that these patients are at a risk? Well, we look at traditional risk factors like age, sex, family history, smoking, hypertension, lipids. We are now identifying new risk factors which, duration of diabetes, low GFRs, proteinuria, so patients who've got a high albuminuria, metabolic syndrome, severe hypoglycemia, presence of MASLD, although it's an NAFLD in NASH, but now we term it as MASLD, and obstructive sleep apneas. Now, these are the more recognizable new risk factors that are associated with cardiovascular disease. Now, you've seen this ADA algorithm, and we have now clear-cut outline to say that yes, healthy behaviors, diabetes self-management, education is important, and then you of course risk stratify an individual. Patients who have a high cardiovascular disease, ASCVD risk, patients who have a high risk of heart failure, CKD, you're not going to wait in a sort of staggered manner to escalate the treatment. You're going to risk profile them early and start using agents given the trial evidence that we've got of reduction of cardiovascular risk. You're going to use your GLP-1s, you're going to use your SGLT2 inhibitors much earlier rather than wait for the disease to progress and patients get into trouble. So you're not going to wait for glycemic control and then say, look, am I going to start using agents that are going to cause a low cardiovascular risk? So you're going to look at using your GLP-1s and SGLT2s much up for patients who've got a high ASCVD risk. And is there an evidence that why is duration of disease important? And that data comes from the UK PDS Accord Advance and VADT trials, which show that early intervention, the benefits last, and then you've got a legacy effect which continues over a duration of time. But patients who started late intensifications do not get the benefit. And in fact, in the Accord study, they had a higher mortality. So you have to intervene and get your sugars to better goals. Start intervening to identify all cardiovascular risk markers and address them early, even within the pre-diabetic range, rather than wait for these patients to develop over diabetes at a later point of time. Here's another study which looked at the benefits of multiple risk intervention, and you can clearly see here that patients who come with diabetes and 1 or 2 risk factors, 3 or 4 risk factors, 5 or 6 risk factors, or 7 or 9 risk factors. The higher number of risk factors that the patient has got, there is a higher transition to high ASCVD risk. And you don't wait for each of these risks to sort of, get sequentially treated. You have to treat them all together because that's where the benefit lies. And this is what the Steno 2 showed us, that multiple risk interventions with intensive therapy, the patient does much better than you doing a sequential therapy. And this is one study. Then you've got the InterHeart 9 study, which again showed that if you address all 9 risk factors, the benefit is exponentially high as compared to when you individually look at these risk factors. So I just want to end up with some key messages. What do we understand? Patients with diabetes are at an increased risk for coronary heart disease. There's no question, we have good data about it. Are all patients with diabetes to be treated as coronary heart disease equivalents? That's questionable and we don't have convincing data about it. Can we identify populations of patients which need more intensive care for aggressive intervention? Sure. Look at the age, duration of diabetes, lifetime risk versus short-term risk, total risk burden, coronary artery calcium scores. Do we do everybody a screening for coronary artery disease? The answer is no. There's no convincing data about it. And obviously, there is a great data to show that prevention strategies should be started early in the course if we want to reduce the burden of cardiovascular disease down. Where does it all start? I mean, we have now a lot of evidence which shows that all these risk profiles start even in younger age groups. It's only that the progressors tend to start, we don't follow them up as they show changes. And by the time we identify them, it's already too late. So we've got to identify these high-risk progressors if we want to reduce the burden of disease. And clearly, patients who are hyperglycemic, obese, sedentary, dyslipidemic, presence of hypertension, procoagulant states, endothelial dysfunction, high inflammation, that's where HSCRP perhaps comes to use. These are all potential reasons why somebody would tend to have a high ASCVD risk. These are the AHAs actually check life's essential 8, sleep well, eat healthy, exercise daily, monitor your blood sugars, check your weights, get your lipids in goal, monitor your blood pressures, and stop smoking if you do that. I think these are the healthy 8, essential 8 that the AHA promotes. Thank you very much for your patient listening.
Thank you, Dr. Agarwal. That is a very educative talk. And are there any questions from the audience?
There's good data to show that HSCRP is a good risk equivalent, but don't use it in isolation. So, often you come across patients who've got HSCRP that is elevated, but the patient has no other risk markers. It is just a red flag for you to say that you need to see this patient more carefully and monitor them ahead. But only on a HSCRP elevation, you're not going to, give them escalating therapies.
No, because HbA1c may be 5. But the H1,
that's the more risk factors you're able to accumulate, it's just a red flag for you to identify that this patient needs a more careful follow-up and that you need to follow them up.
What are the genetic factors involved? You said genetics is important.
Family history of cardiac disease, family history of hypertension that you look at. So map out the family history and see who are the patients. So obviously if you have a first degree relative or one of your parents has a disease, you are at a higher risk for sure.
So for prediabetes?
Prediabetes as well as cardiovascular risk, both.
IFG is early beta cell dysfunction, IFG. IGT is more of insulin resistance.
I'm sorry, I didn't understand your question.
Impaired fasting glucose is a mild decline in beta cell function.
Yes.
IGT is more of insulin resistance.
It's the other way around actually. IFG is insulin resistance and IGT is more of a secretory defect.
Both belong to pre-diabetes, but which one has got more chances for that?
See, the IGT has got more correlation as compared to IFG. So always today we talk about postprandial lipemia, postprandial glucose, that has got a high cardiovascular risk as compared to fasting. So there's enough studies to show that people don't call for fasting lipid profiles anymore. They say do a postprandial lipid profile because postprandial lipemia has got a higher cardiovascular risk as compared to fasting lipid profiles. And that goes true even for postprandial blood glucose.
The triglyceride will be invariably high.
So if you have anybody with more than 350 triglyceride value, then call them back with a fasting to redo it again. So if you have somebody who's got, let's say, postprandial triglyceride value of 450, 500 or something like that, so you want to avoid because it's only the triglycerides that gets affected with the meal, not the other fractions. So if you have somebody which has got a high fraction, it's always prudent, and that's what the guidelines say, that call them back again with the fasting state, overnight fasting state, to redo their triglyceride values.
One question for me, sir.
Sure.
Between HbA1c and the blood sugars, is HbA1c really reliable for detecting prediabetes, or would blood sugars
Is HbA1c?
more reliable or less reliable than the blood sugars in detecting prediabetes?
I think, see, if you look at the ADA criteria, we've got fasting, we've got post-meal, and we've got A1C. And in the A1C, it's an independent factor for diagnosis of diabetes, if you look at the ADA criteria for diagnosis. Now, if you've got a normal fasting and you've got a normal post-meal, and often patients come to us with a A1C value of, let's say, 6.2 and 6.3, right? I go back and see what is the risk profile for diabetes that the patient has got. Is the patient, woman, she had a gestational diabetes? Is there a family history? Has there been any other reasons? I would ask them to do a complete day's profile and see if the patient's sugars are normal, right? If I don't find any evidence of altered blood glucose, but only an A1C elevated, I will just monitor this patient. Obviously, ask him to have healthy eating habits, take control of his weight, exercise him every day, and serially monitor him every 3 months or 6 months to look at his glucose profiles and A1C. But isolated A1C alone, which is in the pre-diabetic range, I'm not going to treat him with metformin.
One more question, sir. When would you use metformin, pioglitazone, and acarbose or voglibose for pre-diabetic patients?
Okay. There is data with metformin clearly, right? Because there's enough evidence to show, and you've got Dr. Ramchandran's data from the IPDS study and many other DPP study and all these things which have shown that with metformin, you have patients who they become more normoglycemic. The data with voglibose or with SGLT2 inhibitors is not very strong in pre-diabetics. They haven't been done so much. But yes, if theoretically you ask me and you want to have zero conversion rates, then a combination of, let's say, pioglitazone, SGLT2 inhibitors, and a GLP-1, you'll have zero conversion. But that's as good as treating diabetes in that case.
If there are no more questions, we'll wind up the session. That is very informative talk from Dr. Sanjay Agarwal. Let us give him a big hand.
Thank you very much. Thanks a lot.
Thank you, dear Chairperson. And